Hi, everyone. Thank you so much for joining me as we talk about how you can use point-of-care ultrasound in the crashing neonate. By the end of this talk, you'll understand the various applications of neonatal POCUS, and you'll understand how to use POCUS to rapidly assess the crashing neonate and attempts to figure out what is going on and quickly intervene. We're also going to very briefly highlight some different protocols that can be used to evaluate the crashing neonate in hopes that you can adopt some of these and take them back in your own unit. So, application of POCUS and the crashing neonate. Why would we use POCUS? Well, POCUS is readily available. It's usually right in the unit if you have an ultrasound machine. You can rapidly assess the infant within several minutes or even in between pauses of chest compressions to really figure out what is happening to guide your initial resuscitative steps. You can also use multiple different types of probes, so you don't have to have all three probes. You don't have to interchange between the probes to be able to very quickly find big, bad, dangerous things that are causing your infant to collapse. So, to review the applications, a preterm infant with acute hypotension, you can put the probe on the chest subcostal and evaluate for a large pericardial effusion. So, to the left, you see an apical view of the heart. You can see that the heart is beating. However, there's this large black area around the heart. Just as a reminder, black on ultrasound is fluid. So this is a large pericardial effusion. On the right, you will notice a normal heart without that large black rim around it. Now, you may ask yourself, how am I going to tell between a small pericardial effusion that's not causing a problem and a large pericardial effusion that is causing a problem? My guidance for anyone that's looking or and doing this is that if you have to question, is it big enough? Do I really think that's the problem? It is probably not the issue. We're not looking for small things here in the crashing infant. We're looking for big, bad things that you can't miss. So, preterm neonate with acute hypotension, you went subcostal, there's no large pericardial effusion. Now you go up to parasternal lung and you're looking to see what is the function of the heart. Is this a baby that's pre-code? Is this a baby already in a code? The first image is a parasternal lung view where you can see that the right ventricle, the aorta, and the left atrium are all similar sizes and the function looks good. Here is a view where the right ventricle, so at the very top of the picture, is dilated and actually squishing on the left ventricle. And then lastly, in this view, you see the left ventricle very dilated and really not functioning very well. In POCUS, we are not doing a targeted neonatal echo with different qualitative measurements. What we're looking at is it obviously bad or not? You can see on the picture all the way to the right in comparison to the picture all the way to the left. This is obviously different. You can see that the mitral valve is barely opening. This baby has severe cardiac dysfunction. Same baby, preterm neonate with acute hypotension. Now, you've looked and you said there's no pericardial effusion. The function looks okay. What else could be going on? On the left, you see a baby with a very hyperdynamic or underfilled heart. We like to say that the ventricle endocardium is kissing here. It's so close together that you really don't have enough time to fill the heart. To the right, you'll notice a subcostal view where the liver is to the left corner and the IVC is just really squished. So this goes along with a baby who has an underfilled heart and likely is hypovolemic. A point to mention here, if you see the image on the left with the underfilled apical view of the hyperdynamic heart, however, on the right, instead of a collapsed IVC, you see a very distended IVC. That means that you are likely not hypovolemic, but there is something preventing getting volume into the heart. That something preventing it could either be severe right ventricular cardiac failure or that your mean airway pressure is too high. I want to give a quick shout out to Gabriel Altit and the Neocardio Lab who provided me with these images. So, same baby, acute hypotension. You looked at the heart and you say, it's not underfilled. There's no pericardial effusion. There's no big issue with cardiac function. What else could be going on? In this baby, you see the liver, a PIC, and the PIC is actually traversing through the IVC into the right atrium, and you see that PIC flipping around in the right atrium. When you move the legs, actually, in this baby, all it took was straightening the legs from the curled up position that they like to sleep in to the straight leg position that we like to put lines in that position in. When you put them in the straight out position, the PIC was in a beautiful location. However, when you would let go of the legs, it would immediately go back into the right atrium, tickling the SA node and causing dysrhythmia and cardiac dysfunction. So it's not all about the heart. As much as I love cardiac POCUS and I love learning more and looking at the heart, a lot of times it's actually the lungs. So this baby, acute respiratory failure, the first thing you're going to go for is there a pneumothorax? Now, I still, even though we use POCUS routinely, will have people say, do you want me to grab a transilluminator? No, I don't want you to grab a transilluminator because we've all seen the babies that are basically see-through, and you put the transilluminator on their chest and the entire child lights up. Super unhelpful. Or a baby with severe anasarca, you put the transilluminator on the chest and nothing lights up because it can't get through. For me, I prefer to put the ultrasound probe on the chest. And what you're looking for, the big cheat here is, are there B lines? So as a reminder, B lines are areas of fluid-filled lung or interlobar fibrosis that we see in babies with chronic lung disease. We are at a huge advantage point here in neonatology because our babies rarely have normal lungs. They rarely have lungs that have no B lines. So if you see a baby whose left lung looks like the picture labeled A with gorgeous A lines, reverberation artifacts from the pleural line, and then you have the right lung looking like picture B, tons of B lines, that baby has a pneumothorax until proven otherwise. Now, yes, A lines can be normal. And if you don't have this big discrepancy between A lines in one part of the lung and B lines in the other, what you can do then is look for normal lung sliding. Normal lung sliding, I typically use M mode. And yes, you can do it in 2D and look for the ants marching on the pleural line, which we will talk about, or you've already looked at the lung ultrasound talk. For me, M mode is much easier to see. So M mode is looking at the motion down the line of interrogation. And I want to draw your attention to the picture that is now in the right of the screen. What you see here is the left side has these static lines at the top, a bright white line where the arrow is, that is pointing to the pleural line, and then this kind of wavy motion or a beach seashore appearance below. That is where the visceral and parietal pleura are still attached and are moving with respiration. To the right of that picture, you see these static white lines all the way down. This is called a barcode sign or stratosphere sign. This is where the visceral and parietal pleura are separated, where there's air between the visceral parietal pleura, and you have your pneumothorax. Okay, so you did a quick check in this baby with acute respiratory failure. You didn't see a pneumothorax, you saw B lines everywhere. Now what do you do? So now I go to zone 3, which is your axillary zone, and I look to see, is there a large pleural effusion? As a reminder, in ultrasound, black is fluid, which is different than an X-ray. So here is a baby with a very large pleural effusion. You see subcutaneous tissue at the top. You see the little white areas that are the ribs, large black area that is the pleural effusion. And then you see the poor little atelectatic collapsed lung that looks like what you would think an organ of a lung would look like, which is called hepatization of the lung and ultrasound, just floating around in that fluid. Now, you will sometimes find very small areas of fluid where there's just a tiny rim of fluid and the lung is right next to it. That is not going to be the cause of your problem. And again, if you have to sit there and try to find the fluid and say, "Oh, is that what's causing it? I don't know. Is it enough?" It is likely not enough. What you're looking for, again, is big, bad things that are causing your baby to collapse. Here's another baby, acute abdominal distension and respiratory failure. So now we've looked at the chest, we've evaluated, there's no pneumothorax, there's no large pleural effusion, there's no large pericardial effusion, the cardiac function looks okay, the cardiac filling looks okay. Let's go find other things. So in this baby, the chest x-ray had this little lucency. You said that is not what's causing our baby to be sick. However, I can't find another cause. Let me look with ultrasound. And on ultrasound, you see this very nasty picture of the liver. This is a baby with a TPNoma where the UVC had infiltrated into the liver and was causing the baby to acutely go into shock. When this was found, the fluids running to the UVC were stopped. The UVC was pulled to a low lying and then removed when other access was obtained, and the baby was volume resuscitated and started on antibiotics. Another baby, acute abdominal distension, respiratory failure. Nothing on the x-ray is really helping you, so you do an ultrasound. What you see here is complete absence of peristalsis, areas of thickened bowel wall with white areas that look like pneumatosis. And in the still, you see these white lines going up to where your probe is. Those are reverberation artifacts from air. And what we found here was a baby with free air that had not yet accumulated enough to show on x-ray. Yet the problem in this baby was definitely the belly. And rather than waiting for the baby to get much worse and to go into shock with free air, we were able to early diagnose free air with ultrasound and contact the surgeons quickly. So there are other protocols to evaluate the crashing neonate that I didn't go through in this talk yet. The big one that I tend to use, so there's the safe and the safer protocol, and then there's the crashing neonatal protocol. The safer protocol says you can do 2 hours of hands-on lung ultrasound training, which we are going to do tomorrow, or whenever you are watching this talk. People with less than 3 months of experience can accurately perform it. You get to do this before the x-ray or the echo ever come to the bedside. And what they found is in 12 crashing neonates with 2 hours of hands-on and a less than 3 months experience, people accurately diagnosed pneumothoraces and pericardial effusions and did needle aspirations and put in chest tubes. And what they evaluated is tamponade from cardiac tension pneumothorax causing tamponade, large effusions, ascites, intestinal concerns, and one thing that I didn't go over, show you pictures of, is the catastrophic intraventricular hemorrhage. So here's a picture of the safer. I do want to draw your attention to item number 4. We do not do item number 4 in our NICU. We do not evaluate for a critical aortic occlusion. If you are concerned for congenital heart disease as a cause of your baby decompensating, we will still do POCUS while we wait for the echo to get there, but we are not teaching people to Doppler the aorta and evaluate for critical coarc. Here's the crashing neonatal protocol. Again, it includes cranial POCUS, looking for that severe IVH. It's not going to be subtle. We are not looking for grade 1, grade 2, small grade 3. or small grade 4. What we're looking for is something massive. All of the blood has drained from your baby and led to cardiac failure, and it's actually coming from the brain. That's what you're looking for. Lung POCUS, again, looking for an effusion. And then if you do that, needle, looking at consolidation. If you see complete atelectasis of the lungs, adjust your map. Looking for a pneumothorax, needle. If you have a baby who on lung ultrasound looks great, not a lot of B lines, but you move to cardiac and you have no filling and an IVC that's super dilated, that tells you to reduce your map. If you're looking for fluid around the heart, do a pericardiocentesis. Cardiac failure, start early inotropy prior to getting your echo. Severe pulmonary hypertension, that is not something that we do in our unit for cardiac POCUS. If you get to that space where you see a baby where the right heart's dilated and it's pushing on the left heart, in our practice, what we recommend is to get a formalized echo stat in order to evaluate for pulmonary hypertension. However, if the baby is really crashing, we are okay with you starting nitric. However, there needs to be a cardiac echo done very, very quickly, either by cardiology or a targeted neonatal echo done by neonatology. And then lastly, abdominal POCUS, massive amounts of fluid, gut ischemia, and free air. So in conclusion, POCUS can really be used to rapidly identify the cause of an acute decompensation in a neonate. And it can be done after having a several-hour course and going back and getting used to seeing what normal looks like on point-of-care ultrasound so that when your baby's crashing, you can see what the big, bad, abnormal thing is. I recommend using a standardized approach. Whatever protocol you want to use, I think it's fine as long as you're doing it routinely, you have a standardized method of how to do it. And that way you can quickly evaluate what's going on with your baby. Your team knows what you're going to do and what timing, especially if you're trying to do things in between chest compressions when they're checking for pulses. So there are various protocols to help guide you for your standardized approach. I will share the sites for these in our course so that you can review the literature. These protocols have a lot of great literature sites embedded in them, as well as quality-based evidence that you can use to go back and educate your peers, use for hospital administration approval to be able to build these type of programs in your NICU. Thank you again for joining, and I look forward to seeing everybody at the course.